You're listening to Health Innovators, a podcast and video show about the leaders, influencers, and early adopters who are shaping the future of healthcare. I'm your host, Dr. Roxy Mooney. Welcome back, Health Innovators. On today's episode, we are doing something really crazy. We are flipping the script. Typically, we are pure interview show where I'm interviewing a guest one-on-one. And today we're doing something really different. I've invited 3 guests to join me today for us to have a somewhat different conversation. So instead of just explaining about the commercialization and the healthcare innovation journey, we're actually going to problem solve. We are going to talk about ideas, thoughts, and real-time actions, solutions that you can implement right now. And so we're going to talk about some of the challenges that we're facing in healthcare innovation, and then, like I said, some ways that we can solve it. So first off, let me introduce you to our fearless guests who have actually agreed to this. We don't know each other. We've never met each other before. They don't know each other, and I've never met them. Of course, we've had some communication via digital channels to get to know one another, but I'm really excited about this very organic conversation that we're going to be trying out today. So if you like it, please let me know, and we'll continue to do more of these. So Brent, let me introduce you first. So Brent Wright, who is the Dean of Rural Health Innovation at the University of Louisville. Welcome.
Thank you. It's Associate Dean.
Associate Dean. Okay. Mm-hmm. Thanks for setting me straight. And then we also have Jef Carlisle with us. He is the President of Pneuma Systems Corporation. Welcome, Jef.
Thank you. Nice to be here.
And Howard Rosen. He is the founder and president of LifeWIRE.
Looking forward to the discussion.
Awesome. So what I'd like to do before we get started into the topic of today is just to kind of give each one of you an opportunity, just share a little bit about, no more than 2 minutes about your background and what you're innovating these days. Let's start off with you, Jef.
Well, I'm a 40-year serial entrepreneur. I've worked in some big companies as an intrapreneur, but all in the world of medical devices. So started off in fluid flow control and then went into cardiology related products and ended going back into fluid flow control. So today we're working on a disruptive technology for intravenous infusion therapy. So we're taking the legacy devices and reducing their size and weight by 95%, reducing their cost by 80%, increasing the sophistication by an order of magnitude, and really being driven by the respect for changes in workflow and information flow. Although the disruption nominally comes from fluid flow, the real disruption comes when you tie together fluid flow, information flow, and workflow.
Wow, that's fantastic. Can't wait to learn more. Howard?
So again, LifeWIRE, I'm a typical health IT story by education. I have an MBA in International Finance and Marketing. So naturally with that, I spent 20 years producing film and television, which is a natural segue into health IT.
Yeah,
it's a similar story, exactly. And there is a story behind that, and it does involve some bottles of wine. But in all that, I came up with the idea of what has become LifeWIRE about 15 years ago, which I've been doing this. Essentially, what LifeWIRE has evolved into is a cloud-based communication platform that allows patients and providers to have an ongoing dialogue as if they're in front of each other, but an automated and remote basis. What drove me from the film and television world is engagement. And so the key thing is reducing barriers. So part of the technology or the patents that we have is the patient can choose whatever device they want. So it could be a cell phone, a tablet, a computer, a landline, even a flip phone. And they can choose whatever however they want to communicate. So it could be text, email, interactive voice, chat, instant messaging. We actually now tie into over 400 wearables and medical devices. It's instantaneous communication. There is no software. There is no app. There's no equipment. It's truly using the cloud, power of the cloud, to using whatever is native on the individual's device. Instead of telling them how to communicate, they tell us, and opens the communication flows from there.
Wow.
Consumer in control. I like it.
Exactly.
And Brent?
All right. Thank you, Roxy. I have a varied background from family physician by training to more of an applied technologist now with my work as an associate dean. I love technology. I love looking at how that can be applied to rural healthcare populations, something that we're looking at very closely now is smart glass technology. Often people tend to look at that as Google Glass. You know, if you look at the pandemic and how telehealth helped to transform, you know, how we delivered healthcare, it actually was the only way we could deliver healthcare in many settings for a long time during the initial time of the pandemic. Looking at smart glass technology and how you can bring expertise to the patient, regardless of their location, and changing that telehealth paradigm where you brought someone into a facility that was heavily inundated with technology so you could broadcast to a remote specialist. Now, technology is so mobile and so fluid, utilizing smart glasses to allow the expertise to be there, to allow a person to act as a clinical avatar for the remote expert and really break down barriers and make expertise in healthcare much more fluid.
Wow.
Very
That's
cool.
super exciting.
Very cool.
Yeah.
So very diverse backgrounds. And I think that's what's going to make this conversation just so interesting. So today's topic, we're talking about breaking through the status quo. We're talking about dethroning incumbents, and we're talking about navigating consolidation. So Brent, just start us off by telling us some of the things that you are currently observing in maybe in the last few months or now in the landscape as it might relate to any one of those three phenomenons.
You know, I'm going to start off with something and maybe make a controversial statement here. I think in innovation, I think maybe we have too much innovation. And I think we have an overabundance in innovation. Now, let me, explain that. And that is, if you look at healthcare, it is so important to develop and to advance care that we've not coordinated care well. And where I live in, my training and background in primary care is that we deal with the coordination of healthcare and healthcare data every day. Not to the optimization of patient care, but I think to the detriment, because we're always on the cutting edge, on the bleeding edge of what healthcare does. I really would like to, bring in that, do we have too much innovation or do we temper our innovation appropriately? I'm always going to be for innovation. And then when we talk about the status quo, your question is, I really divide that out into one of these yes and no diagrams. If you do diagnosis, you get a test and you go yes or no, whether the test is positive or negative. I think when you look at the status quo, you have to ask yourself, you have to apply disruption. Does it need disruption or does it not? Does it need innovation or does it not? Because I think we can waste a lot of time on attacking status quo areas that actually are good, that may be an appropriate incumbency. But, in status quo, healthcare, we all have to realize that healthcare is so incumbent. I mean, healthcare is like 20, 30 years incumbent. So we have to be very, very careful. But right now, I think we're really heading into the appropriate time if you're going to be a healthcare innovator to make great changes. But again, back to my original point, do we have an overabundance of innovation? Because I see people innovating in spaces that really create more problems, because as we innovate, we create fragmentation. And that fragmentation, for me, someone trained as a clinician, as a physician, that just makes it more difficult. So I'm interested in Howard's solution there. I think that sounds like something that can really be a benefit, into what we're dealing with.
Okay.
Again, if it's okay just to jump in. Oh, sorry.
Yeah.
I just wanted to say that your comment wasn't controversial. I don't think that I see innovation as being one of three arrows in your quiver. Sometimes the status quo is exactly the right thing to do. Sometimes reversion is the right thing to do. Let's go back to what we used to do. And innovation just gives you another tool, right? It's not, it by itself is not of any value. It's only of value if it achieves the intended objective. So I agree. People ask me, I wrote a book called We Love Innovation So Long as It's Nothing New. And one of the things people ask is, how do you create innovation? I said, well, to Brent's point, maybe you don't want to, but the real key is, if you do want to create innovation, you don't have to do anything. You just have to work real hard at not killing it. Right? It'll be there like a virus. It's there. It's going to be there. Just quit killing it, and it will happen. But you don't need to do anything.
Right.
to actually increase it.
I love your points on creation there, because to me, I think it's important to draw a boundary between creation and innovation. I've always seen innovation as taking existing parts and putting them together. I think that can be very important to innovation. Sometimes if you try to create too much, you can actually, one, there's a time factor there, and one, does it need to be created like an invention? It's sort of an inventor's paradox there. The invention versus just an innovation. So, innovation to me is making things better appropriately, to your point.
It's interesting. I think it's all preaching to the choir here, depending where Roxy sits. But it's also, what is innovation? Like, you've got talk about the corporates in terms of, people say, well, you've got to innovate. Well, what does that mean in terms of, if it's making more apps, for example, you've got the app fatigue on the average patient or even physician is insane right now. So that's not innovation. And to Jeff's point, sometimes innovation is having the determination to say, you know what, we're actually on the path we need to be on right now. Just the premise behind what I did, to me, innovation, the ultimate innovation, what we do is where the technology is invisible. You don't want to see that. You just want things to happen, and as simply and easily as possible. And sometimes, yes, reversion, but I think innovation in itself is that's the controversial word of the whole thing, is because what is innovation?
Yeah, exactly. And, one of the things that comes to mind when I hear you guys speaking is there's a big difference between like being technology or product obsessed and being customer obsessed, and really solving a real problem that people are facing versus just innovating for the sake of innovating because it's sexy. And I think that's why we have so many innovations that end up in the zombie graveyard, because they were never needed to begin with.
or they may be adopted. You take a look at a typical acute care electronic medical record system. It gets adopted at great expense. Yeah. And there are many patients that would be better off with a thoughtful 3x5 card.
Yeah.
Instead of 15 gigabytes of data.
I can't hug you through Zoom. You're exactly right. Thank you for saying that.
Well, that's great, because a lot of the time you've got, and we experience it, we've seen it, is IT departments are saying, oh man, this is so cool. This new Ultra X, Y, and Z, everyone's got to use it. But because in their perspective, it's cool. The average perspective, it may not be. And it's sort of that balance in terms of saying, just because it's cool doesn't mean it has the value that it should. And to Jeff's point, you have, and Brent's, you still have to have a value proposition. How is it, what pain point are you solving by doing so? And at what cost? And at what cost?
Well, some of these things are so expensive and so difficult that you say, well, if it's this expensive and this difficult, it must be valuable. But if you take a look at, quote, smart pump, infusion pump technology, how could you argue against it? Oh, and you can pick up an anecdote like that, and you can mention, how could you argue against it? But if you look at where is the Lexus of information, what is it you're trying to achieve? It absolutely, and no doubt in my mind, causes more harm than good. It creates the illusion of safety because it's so difficult and so laborious and so expensive, but it doesn't really move the needle, no pun intended.
I like it. Keep being punny, Jeff. Keep being punny. So the status quo, how is, to your point that you guys are talking about, how does that help us or how does that hinder us? And for those folks that are in the audience that are at different points of the innovation process, how do they overcome some of the just traditional status quo that we have? And when and how do they identify that this is a status quo that's a good thing and that I should just leave that alone?
Just jump to the end user, right? Look at the end user and say, are there unmet needs? And you start there and you end there, because once you've created a solution to an unmet need, it's the power of the consumer voice that will influence an organization. It's not going to be the R&D team. It won't be the manufacturing team. It'll be the sales guy who finds out from his customer, hey, these guys are talking about something that's really, really interesting to my customers, to the end users, or to the patients, or the pharmacist, or whoever. And So you really have to start with, have you satisfied an end user unmet need?
Actually, it's interesting. It's also identifying the end user. Let's use, this horrible COVID pandemic and the explosion of telehealth.
Yeah.
Where all the salesmen were making sales to the providers and the payers, and they weren't as interested in telehealth. But if you ask the patients, they said, I want to communicate, I want to, get this information as much as possible. But the providers and payers and, the sales are oriented to them. With the, COVID, all the horrible things, the one thing that I think people started recognizing, oh, we need to satisfy the patient for what their needs are and have them be able to access the system. And I think there's very few patients went, oh my gosh, this telehealth thing, isn't this great? As opposed to, where has it been? We've been asking for it, but not been able to get it. Which again, it's just being aware of that end user is ultimately the biggest important piece, because that's what you need to satisfy in innovation and in the business proposition for the innovation. Because if it's not going to be, you can build it, but if it's not going to be used, as I said, it's going to go to the zombie graveyard.
Mm-hmm, mm-hmm. Yeah, it makes me think of a couple of things. One is, a lot of the research that I've done is really say that it starts off with an early adoption lens. And when you're building out your commercialization strategy, thinking about that for your segmentation, because if you're trying to sell your solution to the mainstream market, you're just beating a dead horse, right? Like those are the people that are digging their heels in and they love the status quo. Like they are so risk averse. They're never going to buy something, even like what you were describing, right, Howard? Even if there is a real need from the end user, they're just like, no, not until it becomes an industry standard and until all the peers in my community are telling me that I can trust it. I don't care what the brand says. Any comments or any experience around that type of lens that might be used in building out that strategy? Well,
certainly from our experience in terms of sales, and it shows my age, but it's like the old days in the old days of computers, no one got fired by buying an IBM product. It wasn't the best, but it was kind of like they were the computer at that time.
Yeah.
And you're seeing that today, quite honestly, in terms of the larger the procurement side is, no one, got fired. If you went with a name brand or did a certain thing that's been done before, continued on what was previously done, they sort of say it's more safety in the work that I'm doing. And it all comes down to how you're measured on those pieces. And that really comes down to, back to the point, is your job to satisfy end user's need, or is it to satisfy something else? And it's really, where's that risk reward for the individuals who are making those decisions as to what direction that they go in. And again, sometimes the status quo is going, okay, well, nothing's going to happen to me if I stay the status quo. Maybe it's a slightly cynical approach to it, but it's kind of the practical realities of the trench warfare out there.
Not nearly cynical enough.
I'll dial it up for the next anecdote.
Yeah. One of the problems we have in our industry is that the end user, the financial payer, the provider, the prescriber, the insurer, the ultimate financial guarantor, they're all different, right? Mm-hmm. So you have all cross purposes, and where there is alignment, like when insurance companies not involved, like LASIK surgery, all of a sudden, holy cow, prices drop like a rock. Availability is there. They get new technology every 24 months. And it's like, it's phenomenal because it wasn't adulterated by insurance.
Yeah.
And dentistry is in a similar vein. There isn't enough, there isn't a big component of insurance or as much in dentistry. And dentist's office looked like the 21st century. Right? You go into the OBGYN place and they got a rabbit's foot hanging over the woman, But you go to a dentist's office and it is 21st century. It really is truly unbelievable.
Oh, my goodness.
Oh, and their primary business of repairing cavities went away. Their entire floor, the base business they had, went away. And now, it's all changed entirely to cosmetics and other...
Sure.
Yeah.
So one of the things that I think you guys are touching on is, the telehealth thing, right? So that movement, that acceleration of adoption, one of the barriers that we're all familiar with is the regulatory and the reimbursement hurdles, right? And so then once that was lifted, you could actually give the consumers what they wanted. And so when I'm working with clients, we talk a lot about, well, is it better to go B2B or B2C? And B2C is a real costly path. And, to what degree are patients going to want to be out of pocket versus, cash pay, out of pocket type of things that they can't get the payment model alignment versus, that's just a barrier that you're not going to be able to overcome. What do you think?
That's a good question in terms of, and it's something we deal with all the time. So our approach, we're B2B2C.
Mm-hmm.
And part of that is for the clients or the patients, when it goes through a provider that they know or a payer that they know, it's basically like, okay, here's a validated product for us to use. Because the problem with just the open, app market, for lack of a better term, or solutions is, how do you decide which works or what's good for me or not good for me as a patient? So we look at it as providing sort of at least a orientation to it. And on the price basis, it's a stratification of a marketplace as to who will pay for what. The average person goes by how many apps can I have? Well, one app is $5 a month, but if I got 10 of them, that's $50 a month.
Right.
Where then you're prioritizing whether you want to play another round of Legends race cars, or you want to weight management. And I think the more it's provided, and it's where you place the values, and the more it's provided through a provider. Just right now, and that could change tomorrow, but right now, at least it's providing a means of validity as to why and which one should I use. And if it's some of the costs, even if it's a copay, at least with some of the costs covered, you have the value, so you're paying something for it, but you know you're getting some reduction in price as well.
I think that's a great question on what the healthcare consumer is willing to pay. You also have to look at, how that breaks down, whether it's in different populations, whether that's Medicaid, Medicare, self-pay, less of that now. But when I would say self-pay now is more people who are willing to pay besides their insurance, like concierge care.
Yep.
The different ways of obtaining care in that way. But what I have found, and a lot of time when you have your bigger payers, more your quasi-governmental or your pseudo-socialized payers like Medicaid, Medicare, those people are very averse to any out-of-pocket charges. I mean, in Medicaid here in our state, we moved from having to pay $1 for a visit to taking that $1 payment away. Couldn't believe that we were arguing about $1, to come in to see someone. So, and, I participated with the program here we tried to roll out with Medicare, where you just had to pay $8 for a monthly telephone evaluation, where you could go over and go through all the data and update and try to aggregate the information better, because we all know that there's issues with aggregation and data sharing when you have a lot of consultants involved in the healthcare process. We wouldn't pay $8 a month out of pocket. And so I've been, that sort of hit me, right between the eyes on how averse people are to paying those. So when you talk about extra, there's going to be a population that pays that premium dollar that say, yeah, it's worth it, $50 for telehealth services. And then people are going to say, well, my time's not worth as much. So I think that pricing discussion is extremely interesting. One we could probably spend a lot more time on.
Yeah.
I think you could take consumerism and personally owned health records. That's about 45 days worth of discussion. It's so important. It is so critically important. $8 a month to try to assimilate a coherent medical record would be worth, and if you tied that to consumerism, to actual shopping, as you know, with any medical procedure, the difference in charges for any one medical procedure is commonly 10 to 1. With no correlation to what you might think of as quality. 10 to 1 is common. There in the Boston area, sometimes it's 40 to 1. And sometimes it's 20 to 1 in the same facility. And so it depends on how you get in. And So ultimately, a coherent, accurate, practical, transportable medical record combined with consumerism on pricing would transform. We could have better quality for half the cost easily if those two things were done.
And that comes down to healthcare education, just across to understand all the, some of the pieces to it. To your point, Brent, to understand what $8 really means compared to what you're getting for it. It's again, because people sort of balance out. I've got a budget, and this is what I'm going to spend on. Again, how do you make that decision? And so it's not understanding. And to your point, Jeff, the value of all these pieces. The average person, understandably, doesn't have a handle on all that. And if they did understand, the logic and rationale is there, but there's so much to learn, and it's so complicated. As we were joking earlier about how complicated.
I would say though that even you, Howard, or you, Brent, or you, Roxy, if you were ill, you're really in an impaired frame of mind to make good judgments. You almost relinquish that to your doctor, or to the state, or to somebody. It's really. It's really a challenge when you're not feeling well, and of course that's when you consume a lot of the healthcare resources.
Hey, it's Dr. Roxy here with a quick break from the conversation. Are you trying to figure out what moves you need to make to survive and thrive in the new COVID economy? I want every health innovator to find their most viable and profitable pivot strategy, which is why I created the COVID Proof Your Business Pivot Kit. The Pivot Kit is a step-by-step framework that helps you find your best pivot strategy. It walks you through 6 categories you need to examine for a 360-degree view of your business. I call them the 6 critical pivot lenses. As you make your way through this comprehensive kit, you'll be armed with the tools, tips, and strategies you need to make sure you can pivot with speed without missing out on critical details and opportunities. Learn more at legacy-dna.com/kit. I'm a caregiver for my 92-year-old grandmother and another relative that's really, really sick, that's in his late 70s or 80s. So I have consumed indirectly a lot more healthcare in the last year on their behalf than I have in my lifetime. I'm not someone that really consumes a lot of healthcare, and it has rocked my world. These are all phenomenons that I've known theoretically or intellectually, but now I'm experiencing them firsthand. And to keep up with all of the medications that my grandmother is allergic to versus the ones that she's on, and how I need to know that in real time and then be able to give that information to all of the different providers. I mean, it's really hard. And I think of myself as like really smart, very organized, very competent in helping her. And come to find out, we just found out last week that she's been on this medication for the last 4 months and she's been itching. And I never put it together that was a side effect from the medication that she was on.
I think we're all shaking our heads, but that's
shame on you.
I know. I was like, I'm so sorry. I feel
but that opens up. But to the question, that's the whole thing. I ran into this with my mother-in-law, who I guess passed, who's 91, and my father-in-law, where we had to become the healthcare navigators, in this case, from 700 miles away. Yeah. And in part because they didn't know what to ask. But second, I talked about medication, and I polled in, an informal poll amongst everybody I've known with elderly parents. I don't think anyone has not run into just medication issues where they've had the wrong medication in the pack, or they've got contraindicated medications in the pack, because you have 5 doctors, each one prescribing something different, and there's nobody coordinating all that. That on its own, now it's not on topic, but just talk about how innovation. If you want innovation, someone can figure out actually to be able to automate that process so you can actually centralize that information, so you're not dealing with these contraindicated medications that can cause, sadly, itching or other more serious conditions.
There are some good innovations. Unfortunately, it was acquired by Amazon, but PillPack is one company that took a very, very seemingly low-tech approach to it. They ship the packages; they're all big labels, and they're all organized, and it's beautiful. It's not a computer in your house or anything. It's very, very nicely done. And they treat you like you're their only client. They're a really good company. Now they got acquired by Amazon, so that's not going to last very long. But it was a really good innovation in a very important field.
But to your point, Roxy, it's not just one person. There's the people around the healthcare continuum, around that person who is also involved in the health. Absolutely.
Yeah.
As part of all this.
Absolutely.
That shouldn't be forgotten as part of the equation of any kind of innovation or whatever going. It goes back to that end user piece. Is also defining who the end user is. You've got an end user, but you have a support person or persons around them who really are part of that.
So you guys touched on EMR systems. And so I think that's a great topic for us to drill a little bit deeper into around incumbents. Right?
Do you mind if I get a beer?
Everybody want to take a break? We'll do a 5-minute break. A bottle of wine, some whiskey.
Yeah, exactly.
I don't know what beer is going to do it, Jeff.
Yeah. I was thinking of a single malt that's over there. But,
right, exactly.
We've got some good products in Kentucky.
I've heard that. Yeah.
Yeah, send us some.
Drinking products, not EMR products.
Oh, I know what he's talking about.
Oh, okay. All right.
We're talking about libations here.
Yeah, all right, okay.
Bourbon. So what do we do about this, right? We know the problem. Be good just for our listeners. Let's just, somebody talk about what is the problem. Jeff, let's go with you because this is going to be interesting and fun. And then what do we do about it? Is there anything we can do or are our hands tied?
It could actually be solved in a very simple way. And that is to, in medical records, think of it not as something that belongs to the insurance company or the state or a doctor, but think of it as the property of the patient. And then you have professionals that help, like that you do on your tax return, help you organize that. And the interoperability can be done in a 3-page document. It does not need to be totally complicated. And it can be done with people like Howard to manage it in every kind of format you can imagine. And so the structure of it can be simple. Now, once you get into the acute care hospital, there is a lock, right now with a handful of companies that really dominate that space. And I think it's just there are simpler approaches to it. And I think there will be innovators with some small hospitals that can be proof sites to show that you can achieve a better clinical result at 1/10 the resources. And that's the right ratio to look for. You don't want something that's 20% better than Epic. Right. You need something that's got to be 50 times better. But it's both in the price and performance. It's going to be, 5 times better at 1/5 the cost, that kind of ratio. It will happen. The system is absolutely broken. But these hospitals, the bigger they get, the more they think they have to follow, the lead of the Cleveland Clinic or somebody. So it's going to be slow in coming. But I think that the key is to get ownership of that simple, transportable, practical, accurate record has to belong to the patient. And there have to be a structure to allow that to be updated and maintained. But it's not a big structure. It's not a very complicated thing. It's a matter of setting standards and allowing that to happen.
I think the real search here is finding a sustainable revenue model. If you look at the HIEs, they were going to give every state an HIE, and then you would get regional HIEs, and they would be like a Federal Reserve where you could exchange information. But if you look at any state HIE, show me one state HIE in the country that's making money. I don't think anybody has any kind of revenue model, much less they may have some revenue models, but they're not sustainable. So if you look at healthcare data, there's no TransUnion, Equifax, Experian that are moving that data, sort of creating that FICO score, creating what's happening. Hey, I was discharged from the ER or I was discharged from the hospital with CHF. My gosh, it's really important that I got home with my Lasix prescription. And I say that because people spend a week in the hospital and they may not get their prescription. And it may not be that it was a fault of writing it. Maybe it was they couldn't get it filled, or they just didn't know that they weren't on Lasix when they left the hospital, or they got put on more LASIKs. We're dealing with very subtle issues here. When I talk about maybe too much innovation, I'll put it in this way. We can transplant organs. That's a big deal. We can't share a CBC from two small towns here in Kentucky or from New York to Chicago if you are on two disparate EMR centers. EMR.
Right. It's worse than that. It's worse than that if you are on the same system. The state of Rhode Island pretty much got, for every primary care doctor, the exact same system for primary care. Everybody had the same system. But if a primary care doctor went from one facility to the next, they couldn't transfer the records to the patient. Now, technically, of course they could, but there wasn't any support structure that allowed them to transfer the records. And that's because the locus was in the wrong place. It was in some doctor's office, didn't belong to the patient. So you highlighted some financial models, and it was the Visa network that allowed the exchange of information, the creation of the ATMs. It's that kind of structure that enabled all that stuff. It's a structure of GPS that allows mapping. It's a structure of all these things. So there is a role to play in a central structure, but the free market really has to have a revenue model to make it work. And it's really worthwhile. The return on investment is enormous. If you've got the right information, not the right data, the right information at the right time,
Agreed.
The cost of treating a patient drops like a rock.
Yeah. So how is that? So who's doing it? Jef, is that a new company you're starting?
No. I've tilted at the windmill of electronic medical records for almost 40 years. When I first met a guy named Dr. Larry Weed, the father of the problem-oriented medical record, I became a zealot. But I thought I was 5 years ahead of the curve, and I wasn't. I was 50.
Oh my goodness!
I've got other fish to fry. Well, I'm following Brent's lead. I'm gonna follow the money. I'm gonna follow where there's a revenue trail, and it ain't there.
So let's wrap up. Oh, Brent, did you want to say something?
Yeah, I was just going to say I'm working with a startup right now, looking at that space.
Good.
Very interesting, and looking at some very counterintuitive plays here, because I think that the real issue, if you think about it, you talk about incumbency, and bear with me here. There's sort of an incumbency of knowledge, and that I'm going to say maybe an incumbency of ignorance, and that I don't think really patients have this conceptualization that I have an electronic medical record, much like I have a bank account, and that needs to reconcile and balance everywhere I go, because we do not have that mindset. If I ran a bank, and I do have banking background, in my work, and if I ran a bank and you gave me a check and you came in, or then you had another check, I didn't deposit that first one, then you were overdrawn, you probably wouldn't keep me as your bank very long. But in healthcare, we're overdrawn on reconciliation every day. In healthcare. And until we get to that point where patients understand that I have to have a reconciliation of my healthcare data, and until you have that place to park it, much like you do with Coinbase, you have to have, where's that information going to reside? It's not going to reside in one HIE. There has to be a way to either reside that information or to continually move it and make sure that people know that it's been updated. I don't need to know necessarily the results of a test, but what's important for me is to know that a test was done. And insurance companies really need doctors to know that MRIs were done, because patients will say an MRI was done 2 years ago when it was done 6 months ago.
Right.
And if I hear that from a history, I may repeat the MRI. But if I know it's 6 months, and sometimes it's such a barrier to gain the knowledge and overutilization of office staff to track something down, you may go ahead and spend the money, and I think to the point that was brought up earlier, a lot of waste. Just this simple mechanism of communicating effectively could reduce a lot of cost and waste in healthcare.
Yeah.
And that's kind of what we try to do is in terms of in our way, because as I said, that last mile connectivity to the patient is using, in whatever communication they want to navigate some of the solution sets or what their clients are doing and be able to pull information that is important to them, using natural language to get a start to it all. Obviously, it's not a full in-depth, grab everything, because there's a lot of reasons why you can't grab all the data from the EHR, even if it's your own information, but it's a start to try to help them navigate some of that. To your point, it's got to be simple, natural language and a question that's understood, so they can get that information. But I think it's as you said, Jeff, ultimately it comes down to whoever thinks they own the data, that's where your problem's going to be. And that's where your opportunities are.
Yeah. Yeah. So we talked about a lot of stuff today, and I want to end this on some actionable insights, things that people that are listening can start implementing now. So we think about some of the barriers and challenges that we've talked about today, and maybe even some of the myths. What's one strategy or tactic? What's one thing that you think the audience can do? It can be, something that they listen to, something that they explore, something that they implement. What is something that they can do to have more success in their commercialization journey as they're navigating this entrepreneurial, corporate innovator, changing the world kind of mission?
Well, first you have to care to do something.
Yeah.
And then secondly, you have to be very respectful and listen to end users. It can't be driven by technology. It can't be driven by copying somebody. It's got to be driven by respectfully, quietly listening, finding out what is an unmet need. And then I think start slow and do pilot programs and keep expanding the pilot. And what you end up selling, and everyone's selling something, you end up selling the results of what you've done, not what you're doing, but the results of what you've done. So it all starts and ends with the end user. And as Howard has said several times, who the heck is the end user? It may not be the patient, it may not be the doctor, it may be an intermediary group. So I don't think there's any one thing, but there are a lot of lessons to be learned and a lot of pitfalls to avoid. So,
and just when doing a market scan, I think to your point, absolutely, the end user. I think we all agree. You look at the end user, but when you're looking at your competitive set, look at to sort of see who you think your competitors. Look to see what they're saying and how they're addressing the end user. Yeah. But also, more importantly, what are they not saying about what they're doing? And you may find that actually that's where the intersection of opportunity exists, where it's not being said.
Right.
Mm-hmm. If it's not being said, it's likely not being done.
Yeah. Good stuff.
I'm going to say this. I still believe in magic. And when I say that I, as we talk about technology, I still believe that there's a magic between two human beings interacting with one another.
Can I just pause for 1 second and go, oh my gosh, why are you not an entrepreneur commercializing innovation if you believe in magic and you're in academia? I don't feel like I come across a lot of people in academia that are like, I believe in magic.
Well, that's why I have, I wear a lot of different hats. And
yeah.
Work in a lot of different areas. But when you look at technology, you have to have an enable. And let me give you an example here. If you look at telehealth usage over the pandemic, it exploded. It's like, 70, 80%. And as soon as people can get back into the office, it just goes down to less than 15%, less than 20%. So if technology was that great, if telehealth was that great, it's a great tool. Okay, it's a tool, but still, there is something that people receive from working with people who care about them and working with office staffs. So what I see in working with an office staff every day and working with providers, throughout the state and throughout the nation is you do have an issue with burnout and fatigue in your healthcare workforce. Mm-hmm. So this is near and dear to my heart, and that when you design innovation, it has to be with workflow in mind. It has to be with efficiency in mind, and keeping that end user. And for me, the end user, the consumer, I look at that as being, that relationship, that doctor-patient relationship. And it's vital, what we're doing here. So thank you for the opportunity today.
Yeah, absolutely. And I think to your point, Brent, is that, not everyone is going to ever really want on-demand self-serve care. And not everyone is going to want to go back face to face and have that high touch human interaction. I think, one of the lessons that we can learn is to not really swing either way. And for us to think about our businesses and programs as hybrid models. Because I think that we're going to see that if we're trying to personalize care for a specific population, even if we're treating or supporting all patients that, have breast cancer, even all those patients with breast cancer aren't going to want to engage in the exact same way as human beings. We're really different. And so the hybrid model, I think, is going to be really important going forward.
Well, as Brent experienced earlier, it's hard to hug in Zoom.
Yeah.
That's right.
Yes, absolutely. So as we wrap up here, if you guys could just give a shout out of how folks can get a hold of you if they want to follow up after the show.
For me, it's easy. You could just email me at Jeffrey Carlisle at me.com. Jeffrey Carlisle at me.com.
Great.
And for me, it's Howard Rosen, which is hrosen at lifewiregroup.com.
And for me, it's r.wright, WRIGHT, at louisville.edu, or connect through me via LinkedIn.
Awesome.
LinkedIn works. LinkedIn works for me too.
Yeah, LinkedIn nearby, yes.
Exactly, right? Well, thank you all for joining me today. It was such a wonderful discussion. I think that we gave the audience a lot of stuff to chew on, a lot of empathy for the challenges that they're facing, hopefully some encouragement, and certainly some wisdom and some things that they can do going forward.
Thank you so much.
Appreciate the opportunity. Thank you.
Thank you so much for listening. I know you're busy working to bring your life-changing innovation to market, and I value your time and attention. To get the latest episodes on your mobile device automatically, subscribe to the show on your favorite podcast app like Apple Podcasts, Spotify, and Stitcher. Thank you for listening, and I appreciate everyone who shared the show with friends and colleagues. See you on the next episode of Health Innovators.